Okay. So I can relate.
Well,
are we going to want it dark? Do you guys want to?
Should we turn the lights on and see if people from listening side? That's good. It's a bit cheerier.
Yeah. It's kind of dark.
Yeah.
We usually give it
A few minutes, yeah.
People don't get
That's what she said. We're not going to start right on time, which is fine. Because of that, I figured I could dive into my banana.
Please do. People will get you straggle into it.
So that's good. You want it? 2 meters or 8 years? Yeah. So, yeah.
Okay.
Actually, I looked at the radar or something. It's like, that's all right. Something like there, you know, I don't know what I'm looking at. I need to just give this away to somebody else. Right.
Or maybe it doesn't.
Right. Studies have
So we're sending a survey to like. Just run and see. Okay, a few people are going to straggling. Okay, great.
So thank you all for coming. I know other people will be coming in.
But I thought we should get going. I want to introduce Ann Keller, who is currently an associate professor of health policy and management at the University of California, Berkeley. And before that, she was actually a member of the faculty for a brief period of time at Department of Political Science at the University of Colorado. And she completed a postdoc with RWJ in health policy research program, in the health policy research program. She is currently also the director for the Robert Wood Johnson Foundation Scholars in Health Policy Research Program for UC Berkeley, UCSF. And her major fields of research are policy administration, organization theory, health policy, and environment health policy, and the role of expertise in public decision making. And she's going to be talking about her research, obviously. She also published a book entitled Scientists in Environmental Policy, The Politics of Objective Advice, which won the Don K. Price Award for the best book in science and technology politics. So, welcome. Thank you so much, Anthony.
That's a very kind introduction. Thanks so much for having me. I'm really delighted to be here to be able to present my research. I've been studying expertise, especially in contested political environments for quite some time. I think when I initially was studying acid rain and climate change, I don't think I knew how contested those domains would become. But luckily, politics has gotten increasingly partisan, and science has gotten increasingly contested over the course of my career. So I picked a good, a good area to study. Little did I know. I'm going to say just a little bit about my PCORI research. I feel like everybody here, I don't have to spell out the acronym for anyone. Does everybody know what PCORI is here? A lot of people are probably on PCORI advisory panels or getting PCORI. This research fits in with a sort of a larger set of projects that I've been doing to look at federal battles over creating technical expertise, creating scientific information. And before I got interested in the PCORI case, I was doing research on the CDC's firearm research program and how that program was designed, how the CDC thought about the program, why they thought it was important to do the program, and then how politically it sort of came under fire and then ultimately was cut. And in some senses, there's a number of cases that I'm thinking about that are coming under what I think is kind of an increasingly sort of contest upstream. We used to, in the United States, we used to fund quite a bit of scientific research, and I think relative to other OECD counterparts, we had quite a bit more public sector funding of science in the United States, and it was bipartisan. And the partisans were willing to have the fight about whether or not information coming from that research stream made sense to change policy or set regulations. They were willing to have that fight at the point of regulation. But now what I'm increasingly seeing is the fight's coming upstream. And producing the information in the first place is now becoming contested. Comparative effectiveness research has I think some important features that mean that it exists in this increasingly contested political environment. And so when I heard that PCORI was part of the ACA and was going to be this sort of new effort at instituting comparative effectiveness research in the United States, I thought, wow, this is going to be interesting. I want to take a look. So I titled this paper and the talk, Impossible Politics, PCORI and the Search for Publicly Funded Comparative Effectiveness Research in the United States, which is a mouthful, but there it is. I'm going to give some background, and I'm going to throw in a little bit of political science theory because it'll help motivate a little bit why I'm interested in this case, but I'm going to try to keep the political science really light. So if people want to dive into the political science theory and questions, then I've got a few slides that can go into a bit more detail there. Because of the political science, my hypotheses, of course, stem from the frameworks that I'm using, and so I think it's important to have that. I'm going to spend some time on the methods. They turn out to be more, well, I'll get to that piece. And as with probably every research study, and I think particularly with qualitative research, sometimes there are twists and turns that you don't anticipate when you embark on the study. So there's some twists and turns in that piece. And then I'm going to talk through the findings and conclusions, and hopefully leave plenty of time for comments. But please stop me as I'm going if there are things that I've rushed by too quickly or you have questions as I'm going. So, so I don't have to go too much background here on what PCORI is, the Patient-Centered Outcomes Research Institute. It was created under the ACA to fund comparative effectiveness research to the tune of $3.5 billion over a 10-year period. Initially, PCORI had to set its research agenda and priorities and had to figure out what its methodology would be. I think it's a way to even figure out how to decide what were going to be the most meritorious grant proposals that were coming in. And then ultimately, its goal is to select and fund the most promising research, and then, of course, disseminate those research findings so that they might actually be used. I think that there's a logic behind federal funding for comparative effectiveness research. I think there's sort of a classic market failure here in kind of the economic sense, that the private sector underproduces comparative effectiveness research, even though it produces a lot of public, in theory, it would produce a lot of public goods. So manufacturers and providers who may have an interest in sort of selling their services in the private sector may have a conflict of interest in engaging in CER, that they want to make sure that the things that they would provide are popular and look effective. And I think payers oftentimes make data proprietary, so even when this is happening in the private sector, it's not necessarily something that patients, for example, might have access to. So there's an argument that maybe there should be a federal role here, even if it's not a strong one. I would argue that who should like comparative effectiveness research, and who wouldn't? Like patients should like it. If you get a diagnosis, you want to know what treatment options you have, and if there's a treatment option that's going to be more effective for you as an individual, you would like probably to have that information. Of course, anyone who's paying for healthcare would probably prefer to spend their dollars on more, not less effective care. So, so there's sort of strong public goods arguments behind federally funding comparative effectiveness research. That doesn't mean that the comparative effectiveness research has done great in terms of its public face. So Grigas, Mono, and Collins have a piece where they look at the Agency for Healthcare Policy and Research, its efforts to engage in comparative effectiveness research and carry that out. They argue, so I think people may know that the sort of precipitating event for really retooling AHCPR and making it AHRQ and sort of taking away its CER function had to do with its recommendations around treatment for low back pain. And back surgeons didn't like the recommendations. And they were very mobilized and very vocal at the point of Congress to say that they thought that the work wasn't done well, the work was biased, the conclusions were incorrect. This agency really needed to just be either cut entirely or massively rethought. Gregesmann and Collins think that there's a larger set of issues going on. It wasn't just that the back surgeons were sort of powerful and effective and saying we don't want this thing. They said that AHCPR was too closely associated with the Clinton administration and healthcare reform efforts under the Clinton administration, and the conservatives already felt like this agency wasn't for them. So already partisanship is sort of playing in here, apart from the particular flap around the low back pain recommendations. Ultimately, there were too few stakeholders who could kind of mobilize and defend AHCPR and the public goods that it was trying to produce. And I think what this speaks to is that potentially there's sort of a fundamental asymmetry in the distribution of the costs and benefits that federally funded CER might provide. So a very focused cost would hit back surgeons if their market share in terms of treating low back pain started to be eroded. But the benefits of CER are much more broadly distributed and don't produce those kinds of really powerful mobilizations. All right, so here comes the political science theory part. Ready? Okay, so James Q. Wilson is a political scientist who has written a lot about how agencies interact with their environments, and there's much more to what his theory is than what I've written up here, but essentially he talks about the concentration of benefits and costs associated with policies. And his argument is, if a policy that's being implemented produces really concentrated costs, like taking away someone's market share for their profession, or it produces really concentrated benefits. Certain kinds of researchers get federal money from the federal government, but that's going to produce mobilization around that policy and around the agency implementing that policy that's more likely, better resourced, quicker. So concentrated costs and benefits. Obviously, groups mobilize against concentrated costs and they mobilize for concentrated benefits. On the flip side, when policies are producing much more distributed costs or benefits, people are like, my tax dollars are going to something I don't really support, but I'm not going to mobilize around a small amount of my tax dollars that are going to something that I don't support. And when they get distributed benefits, they tend not to mobilize super strongly around that too. So there's this asymmetry exists. Wilson has pointed it out. He draws a 2x2 table. He comes up with all sorts of predictions about how the mixture of concentration of benefits and costs shapes agency environments, and I'm not going to go into too much detail on that unless people are interested, and I can dive into that in questions and answers. But for the sake of this, thinking about how the distribution of benefits of CER versus those potential concentrated costs hit the interest group environment matters for who mobilizes around PCORI or any other federally funded CER organization. PCORI isn't an agency in the classic sense, but it has so many of the properties of an actual federal agency that I will slip into the language of referring to it as any other agency. But I also, the fact that it's quasi-public, I think is relevant. All right, so Theodore Lowy, writing before Wilson, so going back in time, has a set of theories that's sort of similar. And I want to just sort of lay out both of them because I think that both of them have informed my thinking and my language. I want to make sure people are on the same page with me. So Lowy actually, instead of thinking about concentrated costs and benefits in those economic terms, he just laid out 3 different types of policies. So distributive policies in Lowy's framework are policies where the federal government is just distributing goods kind of out into society. And that could be something like NIH dollars or any other sort of R&D, where the research community is benefiting. Everybody who's paying paying taxes is funding those budgets, potentially is getting distributed goods. When NIH gets funded, we all potentially get better health, even if we're not directly getting a benefit from NIH. So distributive policies in Lowy's framework are policies that can produce goods that are easily disaggregated. If one more very well mobilized disease organization comes and says, NIH should be funding research on our disease, it's kind of easy to fold them into the mix. So those politics aren't really conflictual. Those disease organizations don't sort of fight against, don't fund those people, fund us. What they say is fund us too. And so it's a less directly conflictual type of politics. Pork policies, bringing the bacon, bringing pork back to your home district has some of the same properties, with less of the upsides of R&D. But these less conflictual policies happen in the distributive arena. Lowy says that regulatory policies, when the state is actually limiting or compelling behavior, produces much more concentrated mobilization, much more, or he doesn't say concentrated mobilization, it produces much more highly conflictual and visible politics. So that organizations are much more likely to organize when regulatory policies are being set to try to make sure that their interests are going to be met. Redistributive policies are not necessarily in the mix with PCORI per se, but the ACA in taxing Cadillac health plans and trying to create benefits for people getting on the exchanges is engaging in redistributive policy. And for Lowy, those are the hardest policies to pass in the United States. And historically, his mapping here has been drawn out. So for me, one of the questions is, why does this organization, PCORI, that sort of funding looks very similar to NIH, why does it also have these characteristics of what Lowy would attribute to regulatory politics when its statute and what it's implementing looks much more like the distributive arena? I think this is my last slide on politics. So I'm not going to even describe what all of these political scientists' theories are, but what I want to sort of show is that while I think political scientists agree fundamentally with Wilson and Lowy about the idea of who mobilizes and why, and that there are some fundamentals there, and they would agree that the shape of a policy, what a policy is designed to do, strongly predicts who will mobilize for or against that policy. Political scientists are arrayed on whether or not they think you can change those circumstances. So Lowy in particular really sort of sees, he says, policies create politics, that they're very tightly coupled, they're very tightly connected. People like Potashnik and Carpenter think that there's things that you can do to sort of fuss with your circumstances. So if you're in a place where you're an organization trying to implement a policy and you have difficult politics, they tend to think there may be some salvation for you, if you will. And I think this is interesting because in some ways, if you look at the way that PCORI is designed, you almost see, it's almost as if the legislators were grappling with exactly this tension between sort of distributive and potentially regulatory politics in PCORI. So on the one hand, this organization is created as a quasi-governmental organization. It does not exist within a department in the federal government. It doesn't answer to a president or a presidential political appointee. The PCORI is funded in part by general revenues, but also this PCORI trust, which is an excise tax on healthcare payers. So some of the entities that could benefit by CER are also sort of paying for it. And there was a lot of emphasis on trying to create a PCORI that was not going to have any regulatory role, no formal role in setting reimbursement rates in Medicare, for example. So no direct ties to CMS reimbursement decision-making, and PCORI is prevented from considering costs in its assessment of comparative effectiveness research. So this was a really heavy attempt to sort of keep PCORI on the distributive side of the equation and not let it bleed into the regulatory side. I think also the idea of patient-centeredness, you can think of that as, that does good work for how we understand comparative effectiveness. I think there's a logic for that from the standpoint of just thinking about what patients' role brings to the delivery of healthcare or brings to designing interventions that can be more effective. So there's a straight argument for why you would bring patients into the mix. The politics argument of why you bring patients into the mix is it's hard to argue against patients. When patient groups show up in Congress and they tell the story about their condition or their child's condition, and they say these are the organizations that are helping us, those stories can be quite powerful in the congressional setting. So mobilizing patients around PCORI may also have this political component, not just a component in sort of making CER better or more effective. So I'm interested in whether or not, clearly the PCORI architects were cognizant of the difficult politics of CER in the United States, but is it enough? Can PCORI kind of survive? So in laying out when I started the research, we were much farther away from anything that might look like termination than we are right now. So PCORI's budget, I think, was zeroed out by the House proposal for fiscal year 2016, along with AHRQ's. The Senate proposal cut AHRQ's budget by only 30%, and I don't think touched PCORI per se. But those politics are sort of we're in process. So it's a very real question about whether or not termination is really near. When I started the research, I knew that this was a potential, but it seemed farther off. It didn't seem quite so pressing. But so I wanted to ask the question of whether or not patients can be an effective sort of mobilized group defending the organization against mobilizations like, for example, the back surgeons around the low back pain recommendations. I think another hypothesis, and actually this one came in, this is one that we sort of developed early on in the research, is that a number of people commenting on PCORI, participating in PCORI's public comments, which is part of our data, began to say this is going to be just another NIH, which is sort of interesting. Like, so what's so bad about NIH? Stable. It's not particularly contested. It's got a big research budget. But I think what people were, and sometimes people didn't spell this out in their comments, they would just say this is going to become another NIH. And I think what the concern is that people who are taking very seriously patient-centeredness and patient involvement were subtly making the argument that at NIH, patient involvement is oftentimes more symbolic and substantive. And so for their hope that PCORI would be different and not move into this sort of NIH realm, I think is kind of where that's coming from. So potentially sort of capture where the patient-centeredness, the patient drive gets replaced by a tighter link between the organization and kind of research interests. And here, career advancement may drive spending and research more than the public goods the research could produce. I'm not going to say particularly that that's necessarily what's happening at NIH, but I think that's the concern about the capture piece. So this is what I'm trying to take a peek at who's mobilizing around PCORI to get a sense of whether or not the structure of PCORI has quelled the potential regulatory politics. So that's the, and I think that there's a point to be made there about, back to the political science literature, about whether or not we understand distributive politics, whether or not distributive politics are less, are becoming more conflictual. So there's that question. But I also think from a public policy standpoint, and just from a standpoint of people who are engaged in CER, it's that if this very kind of public-private version where the public sector is funding CER through PCORI, but the use of the outcome is researchers in the private sector are doing the research, and the products of their research, the uptake of those products happens in the private sector, not because the government is regulating. That's a very sort of American exceptionalist private sector version of CER relative to our OECD counterparts that actually put this function very much more in state hands. So if this can't survive in the US, I think there's an open question of what can. So that's kind of one of the other reasons why I think this is an interesting case. So onto methodology. So I think there are many ways to observe interest group activity. For certain kinds of interest groups and lobbyists, there are reporting requirements. So if your organization spends more than $12,500 in a quarter on lobbying, you have to file reporting requirements. And there's a big record. There's a historical record that allows you to study organizations that are functioning at that level. Many citizens groups, non-professional associations, non-corporate organizations don't spend that much money. And so if you can't use these kind of quantitative figures and filings to study their activity very successfully because they're not spending enough to sort of get into those documents. So many people who study interest groups really just look at these high spenders and look at trends and sort of what they care about and what they're spending and how it shapes policy. And that's a very interesting arena of research. But a lot of what I do in studying citizens groups, I wouldn't capture the thing that's interesting to me if I were using those data. So that brings me to the question, how can you see what interest groups are doing? A lot of sociologists have studied particular interest groups where they get to know the groups, they do participant observation, they do interviews, they follow a group over time, but they can't say something about they can't say something about all of, a whole set of groups participating in some sector because they get to know one organization well. And typically in the literature, people have chosen to study very high functioning patient groups, for example. So it may be that we know most about the outliers and we don't know much about the rest of the community. So I have some background studying patient interest groups through interview and through survey, trying to get at a better understanding of what disease advocacy and patient mobilization looks like. That's a past project, but it's informed what I'm doing here. What I planned to do when I chose to study PCORI was to spend a lot of time interviewing people at PCORI about what their lives were like. How often did they feel like they were interacting in this distributed space versus the regulatory space, and how do they manage that? So what I hoped to do was get interviews with people at PCORI, and through connections that I had with people who knew the director of PCORI. I was able to set up something like 8 interviews. And usually with organization, when you get to know organizations, you start out with interviewing people, and you show up and you interview them, and you are nice and friendly, and they introduce you to their friends, and you get to interview more people if you're nice enough and friendly enough. The morning that I was going to get on the plane to go to the interviews, I had 8 emails canceling the interviews. So my access was denied to PCORI. Somebody got nervous that if people in the organization were on record talking about the regulatory piece, that it would be very bad for PCORI. So I've been able to do 0 interviews with people who are part of PCORI staff, which caused me to have a big shift in my in my approach. So yeah, it was now what? I mean, I guess that I kept thinking there's a silver lining. I thought that I knew there was a there, right? If they were afraid to talk about this thing I was interested in, then there must be something there, which I think also encouraged me to keep trying to tell the story instead of just throwing up my hands and saying, I'm going to move on to another research project. PCORI will figure out what PCORI is going to do without me. I was able to conduct a few interviews, a handful of interviews. I think it's around somewhere between 5 and 8, maybe it's closer to somewhere between there, with key informants who are not PCORI employees. To protect confidentiality, I can't say much more about how I got in touch with those people. But I got some sense of what the organization was experiencing from people who were close to the organization. But certainly not enough to be able to publish or to say, or to be able to claim that I knew something, right? You can't talk to 5 people and be like, I understand what's going on. Unless you talk to really, really key 5 people, I guess. But so plan B of the methods was to look far and wide for any other available data source. So one of the things was to just sort of see who's involved in the PCORI governance, what does their governing board look like, who's in the advisory panels. We also coded board meeting agendas and participants. The agendas are very brief and don't say anything about what the participants, how the public, members of public who showed up, it doesn't say what they said, but we know who showed up, so we know that they took the time, even though we don't know, there's no content, so we know their affiliation, we don't know what they said. We also coded notice and comment periods. There were 3. There's PCORI setting out a definition of patient-centeredness. It's their priorities and the research priorities and research agenda, and then their methods comment period. So we've coded comments for all 3 of those. Notably, the definitions comments don't have any affiliation with them. So we have a whole bunch of comments that we don't know who made them, which to sort of take guesses at who made them. I'll give you some examples in a second. And the one thing I would say about that we've noticed about the notice and comment period is that there are these very episodic takes about who's mobilized and what they're mobilized around. So it's not the same thing as just sort of seeing the stakeholder environment sort of over time. There are these, they happen for a period of time, who's organized and who's paying attention for that particular notice and comment shows up, anybody else might not. We looked at congressional hearings and coded a number of congressional hearings, both what people were commenting on, the nature of their comments, and and who was participating, who's showing up, who's speaking. And then we try to think about other ways to sort of get at, especially potential kind of latent stakeholder activity. Who are the actors that maybe aren't paying that much attention now, but if they had market share that would be threatened, they would mobilize in a heartbeat. That they're aware enough about PCORI that they're monitoring kind of what's going on, even if they're not showing up in these other venues. We looked at a trade association press that we had access to for a short period of time, and then our access got diminished, and we didn't have the research funds to be able to sort of buy back into that because they usually, they're priced for corporations, not for academic researchers. And then we did a lot of, we looked through social media and formal and informal sort of internet news to try to get a sense of what's happening kind of just out there in the internet on PCORI. The one thing I'll say about trying to present this is that none of these pieces of data in itself speaks wholly to one of the hypotheses that I've laid out. And in that sense, it's hard to present all of it because I can't sort of connect one piece of data to one finding. I've got to give you a big glut of data and then try to draw the conclusions out of the overall picture that we're drawing. So here we're really trying to kind of triangulate between all these different visions, knowing that we didn't get to sit down and talk to PCORI about what their experiences are like. So one way I thought to, let me just take a drink so I can get through this next piece without choking or coughing. Okay, so one of the ways that I thought it could be helpful for me to take you through the kind of messiness of the data and the triangulation piece is to really just tell you what I think you're going to see. These are the kinds of conclusions that we're drawing. These are the big picture findings. I'm happy when I go through the data to kind of drill down more deeply, both into the methods and just what we're finding. We definitely find that patients are active, but they never look like a dominant presence. The one thing that I would say about that is that PCORI leadership is it seems to be taking very seriously the idea that they want patient engagement to be real, that they don't want it just to be this symbolic thing that they say, oh, patients were there, so patients must like the outcome. That they actually try to be very vocal about when patient involvement has changed what PCORI has done. Or that even directly when patients have asked for something that researchers didn't exactly want, that the patients have gotten what they wanted and not just the researchers, which I think does demonstrate a little bit of this piece of, this is not just NIH. There are other people whose voice matters. So PCORI's leadership may be elevating, in spite of the fact that numerically patient interest groups and patient participation doesn't look like it's a numerically dominant presence, it may have much more impact because of the way that the leadership is functioning. And one thing I'll sort of say on that is that when I was in some of the key informant interviews, people who sort of knew what PCORI was going through as it was getting established, that one of the really big key decisions at the beginning was whether or not they were going to be a science-first organization or a patient-first organization. And when you look at the board and the makeup of the board, it might be surprising to find out that the patient-first frame was what won. That they basically said, if it comes to the research community telling us what it wants versus the patient community telling us what it wants, we're going to elevate the patient community. We're going to say we're patients first before anything else. Certainly, I think NIH would never say that, right? NIH would always say it's science first. So whether or not that decision-making kind of early on in PCORI is stable is something I can probably say less about, but at least we see there's stories about PCORI that are saying they've really tried to make sure that the patient involvement matters and isn't just the thing where, okay, now the patients are going to speak and then we're all going to move on and do what we were going to do, is it whether or not the patient said something. I think PCORI's governance reflects both the research and patient focus. Researchers are everywhere present. They're very engaged, and the researchers who get involved in PCORI, at least from the kinds of content that we read, from the kinds of comments that they're making, from the kinds of contributions that they're making, they buy the idea of patient-centeredness. There's not a lot of people who are involved who are saying, there are people who make comments who are saying, we don't, a little too much patient here, you get that. But you don't get it at the governance level. If somebody's going to get onto an advisory panel or sort of get into the board, I think that they have to demonstrate a certain level of commitment to what PCORI is doing. Once again, that could be the kind of thing that could change over time in a capture scenario where kind of the science-first model starts to take precedence. So we definitely see that we see a lot of mobilization around PCORI's distributive products. People care a lot about the research dollars flowing through PCORI. So there's a lot of mobilization there that really sort of tells that story. But we definitely see others who are mobilizing particularly because they seem to care about the regulatory impacts. And they're mobilizing kind of in advance of those impacts to be prepared to fight them in some sense. So it looks like, I can't predict, I don't have a crystal ball, I can't say that's exactly what these organizations will do. But if you look at what their literature is like, if you look at their participation, you get the sense that what they're doing is sort of laying the groundwork to say, CER is great, but there's all these reasons why it shouldn't really be directing the way that physicians are making decisions and the way patients are making decisions. We also, I mentioned that we looked at media, at the way that PCORI sort of exists in social media and in internet news. And what we found overall is that if you just Google PCORI, you're going to get a very PCORI-driven story about this organization. So all of the news stories and the websites that talk about PCORI are very influenced by PCORI and PCORI supporters telling the story of what PCORI is about. On the other hand, if you do more concentrated searches, if you actually look for terms where people might be criticizing PCORI, and we use the terms, we search for PCORI and along with the term ration, and we search for the term PCORI along with the terms winners and losers to try to sort of see, and here we're not getting any representative sample of the internet. We're particularly trying to look for people who might be critical. You definitely see pockets of negativity. And there was an interesting thing in finding the websites that were talking about PCORI and rationing, and the idea is PCORI will be used to ration care. About half of the websites who had that language simply sort of misunderstood the structure of PCORI and sort of thought PCORI is designed to ration care. It's going to, this is state-based decision making. But the other half would say, even though PCORI is not designed to ration care, it's definitely going to have that impact. So it was an interesting, I think, bifurcation, and sort of there are people who are very knowledgeable about how this organization is set up, and they still think the regulatory impacts are coming. Doesn't matter how it's set up, that's coming. So that's, and I think that the take-home story with the media piece may be interesting if most people aren't getting their news about PCORI because they're Googling on PCORI. I think most people in the public get their news about PCORI because a website that they go to or a news source that they go to that's conservative or that doesn't like state intrusion in things has one of these negative stories. And so even though the overwhelming amount of content on the internet about PCORI seems positive, it's quite possible that there's people who will only see the negative content. At least part of that. So let me say a little bit here about what we're finding about sort of who's showing up in different forums where PCORI is the topic, or where or that are set up actually as part of PCORI's governance. So its board. I'm just see if I can. The red bar is researchers and clinicians. The green bar is industry. The purple bar is government, which shows up almost exclusively in the PCORI hearings. The patient bar is blue, and then super dark blue is members of Congress, also only relevant for the PCORI hearings. So one of the things I would say is if you look at advisory panels, right here you see the patients they're almost equal in number to kind of the research or the professional community. There seems like there's really heavy balance there. On the board side of it, patients are much less in representation on the board, which may or may not be a big deal in terms of how much patient voice is part of this. They're certainly showing up a lot at the board public meetings where they can make comments. But the patients are also much less in evidence in congressional hearings. The purple line that talks about government, that shows a lot of government presence there, is actually this very sort of neutral thing where somebody who's representing HHS has to say what PCORI is. And they give these very dry technical descriptions about what PCORI is. They don't seem to be favorable or unfavorable. It's just somebody explaining what the PCORI Trust Fund, how it's structured. So a lot of that purple content is this very sort of neutral, just this is informing members of Congress about what this organization does. It doesn't have much valence. What I would say, maybe not surprising thing, but the sobering thing from the PCORI hearings is that when members of Congress are speaking about PCORI, they're critical. We found, I think, 8 instances where members of Congress were, a lot of times they're sitting and hearing about PCORI from all these other stakeholders, but when they actually get up and speak and say what they think about PCORI, they're like, this thing has to go. We don't need to see our research. So we found one member of Congress who was willing to sort of tell the public good side of PCORI. And that we think that's a problem. So this gives us a little bit of a flavor of I'm concerned for PCORI about the drop-off in patient participation in congressional settings, because if patients are going to be the actors who sort of defend PCORI and legitimize the public good story, they're not necessarily showing up in hearings. On the other hand, you don't get to just knock on the door and show up at a hearing. You have to be invited. And so this is really driven by who's holding the hearings and who's paying attention at a congressional level. So there may be some work to be done at that front. I'm not even going to bother with that. That slide sort of repeats data in the first slide. I'm going to say a little bit about coding public comments. We sort of went through, I think, if you're engaged in a lot of content analysis, we went through a very sort of typical process, which is we set out the codes that we thought we set out codes to distinguish the kinds of arguments that we thought people would make about PCORI. And then as we read the public comments, we would go back and revise our code book. Our code book so we added new codes as they emerged. We tried to stabilize the code book and then tested intercoder reliability across the researchers who were doing the coding. The code book got very complex very fast, and as your code book gets complex, your intercoder reliability tanks. So then we tried to step back and simplify the code book so that we were capturing large categories of things, but not trying to capture every nuance in the hearings, or sorry, in the public comments. But so part of what comes out of that is that the finalized codes, what we coded for each public comment, actually is different. We tried to, as often as possible, as often as themes were repeated across the comment periods, we wanted to capture that so we could sort of show variation. But the comment periods really sort of seem to capture different types of participants with making different types of arguments. And so we wanted to be faithful to the variation within those public comments. So what you see here is that in the definitions comments, We coded for state intrusion. I'm going to give you an example of a state intrusion comment because those were fun. Other kinds of criticism about PCORI that wasn't really focused on the state intruding into, not necessarily, sometimes it was state intrusion into the private sector, but it was mostly pitched as state intrusion into the clinic too. And then a lot of people said that they wanted more emphasis on patients. That was a really common thing that came up. So state intrusion, criticism, general support for PCORI, and people who were overall supportive of the mission, but felt like PCORI wasn't going to go far enough in patient-centeredness. In the research agenda, we see a lot of people who are making kind of what we call typical sort of advocacy arguments. PCORI is great, we love it, whatever else it does, it should focus on our disease. PCORI is great, we love it, whatever else it does, it should focus, or it should include in its research portfolio our specialty. So that's what we kind of call specific advocacy. We love it, include us. So this is me, you know, getting a piece of the pie. A lot of concern about access, concern about disparities and dissemination, and then just technical comments about how PCORI is going to sort of carry out its process. You see in the methods that advocacy still continues, even though they've sort of moved the dial about what they're talking about, and we'll see that there's many more technical comments. And then there's this pro-patient and sort of pro-industry frame that came up in the methods comments as well that we didn't really necessarily see. I mean, I guess the pro-patient frame shows up in the definitions around more patients. And overall, we're coding commenter type as industry, professional association, patient, and researcher. There are people who don't neatly fit any of these categories, but to try to keep our coding reliable, these are the ones that showed up most. So I'm going to give you a flavor of what some of the comments look like. This is really typical of the state intrusion comments, although some of them even included, they had terms about, you know, they're talking about fascists and things, so it got even more colorful than this, but lots of caps, lots of people who are upset. We live in America. We should be able to make independent decisions concerning our healthcare, as well as everything else about our personal lives, not bureaucrats in Washington. This person does not like comments either. Not bureaucrats in Washington thinking they know all the answers, and to cover everyone's needs, leave us alone, thank you. There's a polite, I like the, some were less polite. But there's a lot of that flavor in the definitions comments, and we don't have in the definitions comments any identity of who is speaking. But overall, we noticed a huge shift in sort of the level of information about PCORI in going through these comment periods. So here's an example of a specific advocacy comment that was made around the research agenda. They start out in this very routine way of saying thank you for giving us an opportunity to comment. And then they argue, ASN, which leads the fight against kidney disease through education, advocacy, and research, believes chronic kidney disease provides an excellent model for PCORI in the realm of chronic disease research. So this is an example of saying, whatever else you're doing, you should focus on this thing we care about because it fits with your mission, it's important for the public. I mean, couched in a lot of different ways, but this is, and patient groups will do the same thing, right? Not necessarily just professional associations. And that's a lot of what their lobbying is about. They do the same kind of lobbying around NIH. It's very typical. So we see a lot of this. We see some of that advocacy kind of comments in the methods section, but we also get some just very technical discussions about methodology. In section 7, it's recommended that researchers use propensity scores to balance covariate distributions across intervention groups and assess the balance achieved across comparison groups with respect to potential confounding variables. People will go on to talk about whether or not they think that that's going to be appropriate enough or whatever. So they get in, some of them get into these very technical comments about how you carry out this research. And they don't sort of weigh in on PCORI's sort of larger research agenda or its larger mission. So some of these comments really sort of just get down into the weeds. This is a big table that I can give you more data, or we can dive in at some point, but I don't want anybody to have to try to take that in right now. But this shows what I want to do. Here what I'm showing is the type of comments people made by the type of commenter. So the comparison on this slide and the next one is only going to be about the research agenda and the methodology comments, since we didn't actually have we didn't know commenter identity for the definitions comments. So here, this is the research agenda comments by self-identified commenters. And a note there, about only half of the people who commented on the research agenda said who they were. So we only really have half the picture. And we can sort of theorize about who are the likely people to leave their names out. I would say from a political science standpoint, professional associations that take time to comment want the organization to know that they're out there and that they're commenting. So I would say that it's probably more likely to be patients and lay participants who aren't identifying themselves. But it's just a guess at that point. I mean, I think politically speaking, professional associations are just used to saying who they are, and they want their comments tied to their status and their organizational power. So I think we probably are capturing the professional associations pretty well, but there's other people who are commenting who aren't saying who they are. I think 99% of the commenters in the methods comments self-identified. So there's a lot of differences in terms of what we're learning from each of these things. So professional associations overall, if they're going to make any comment at all, they're most likely to make a comment about advocacy. Whatever, we love PCORI, whatever else you're going to do, make sure you include the kinds of things that we work on. Patients care about that and do that a lot. In fact, I would have assumed that patients would have had a higher bar around the specific type of advocacy than anything else. But patients actually are really hitting the access issue much more heavily, or much, in at least 40% of the time when we read a comment from a patient group in the self-identified comments, they're saying, we want to make sure that we're at the table, that we get to participate, and that we get to say what we care about.
Was that access to PCORI or access to healthcare?
To PCORI. Sorry, that's access and transparency. Sometimes people they want transparency about what PCORI is doing, and sometimes they're talking about access to PCORI decision making. So it's absolutely not healthcare. It's access to PCORI process. Okay. So researchers care a lot about dissemination, which is great. They're equally talking about making specific advocacy comments and access as well. Industry seems to care a lot about access, and then much less about advocacy, which in some senses, it was interesting to sort of see whether or not are there pharmaceutical corporations who thought that they should be competing for PCORI research grants, but we have a lot of evidence they don't interact with PCORI as potentially, they don't see it as a distributive organization that's going to distribute goods to them, but they're involved. And one of the things that I would say, well, let me move on to the. This is the distribution of methods comments by type of commenter. Here patients drop off because there are almost no patients participating in the methods comments at all. Very, very low participation in the methods comments. So researchers are there, industry is there, professional associations are there. And I think not surprisingly, these comments tend to be just really technical in nature, although the professional associations are still, in this case, it's the light blue that's coded as advocacy. The professional associations are in there kind of trying to get their advocacy piece in sort of any venue they can. They know how to lobby. And so each venue where we see professional associations show up, they're making that kind of argument. All right, so I think one of the things that I would draw from this is that these organizations are, I mean, certainly, so professional associations, the back search is mobilized to get rid of CPR, but professional associations by and large aren't really expressing they feel like PCORI has potential regulatory presence. I would say, moreover, that they're much more likely to see this as a distributive policy where PCORI is going to create benefits that may accrue to the people who are part of that association. So they tend to really sort of focus on kind of this advocacy piece, and we don't see a lot of concern about, I mean, I thought one of the things we could have seen is a lot of concern about PCORI output minimizing the clinician's role in helping pick treatments. But I didn't see too much of that in these comments. That does show up a little bit, however, and I'm going to just talk a little bit about this. The Partnership to Improve Patient Care was created in March 2009. It predates PCORI, but it comes with the budget, the American Recovery and can't remember what the second R is in the ACT era. This is what Obama did to try to stimulate the economy after the big economic crisis. And he put a lot of money into CER at that point. So this is when Partnership to Improve Patient Care was created. And this is all just sort of taken from their website, although when they participate in PCORI, they bring a lot of this language to their participation there as well. So they sort of give a nod. We all need good information to make good decisions about our health. Comparative clinical effectiveness research can help us, but it's important to make sure research isn't misused in these decisions. And they keep sort of hitting on this potential. CER can be misapplied in ways that unintentionally undermine the patient access to care. And then they make this argument that CER results typically are based on broad population averages that don't reflect differences in the needs of individual patients. They sort of show up with this argument about the way that they think of CER as generating far too, the population averages, the outcomes are far too general to actually be of use in the clinical setting. They're not the only organization that's sort of laying this groundwork. There's some other organizations that are also kind of framing CER in this way. So yeah, it's great. Sure, we all want to do CER research, but when you're actually sitting with a patient and making an individual level decision, none of that outcomes data is actually going to really help you, because your individual is so individual that it doesn't match up. So that sort of seems to me like the type of potential, that seems like an organization that's sort of waiting for controversial recommendations to be publicized. Let's see, what do I want? So pharma has been really, biopharmaceutical companies and pharma in particular have really sort of leaned on PCORI to make sure that any references to cost are kept out of its proceedings. So they really want to make sure that they're considered relevant stakeholders. There's a big flap about whether or not, I think at some point somebody in PCORI or in some part of the definition, they said that drug manufacturers produce bias output, sort of referring to the conflict of interest. If you're trying to sell a product, you're going to try to make that product look better. And that pharma thought that was, they were very upset about that, and a lot of their comments were about trying to sort of counter that perception that they're not unbiased participants in this arena. So they want access, and they want to really keep on top of whether or not costs are being considered by PCORI. So I actually see a lot of, sometimes industry, especially in the methods comments, we've read a lot of letters from industry where it seems like somebody who's leading their research office just really wants to bring their actual experiences, their professional experiences, to bear on what PCORI is trying to do in the most helpful and supportive sense. And I didn't expect that, actually. I didn't expect that I would see that kind of participation. But you see these letters where they're really going through, this is what's been hard for us about when we try to do this, when we try to demonstrate effectiveness. This is where the methodology gets difficult. PCORI should think about this. And it seems very supportive. So I don't want to undermine that side of the story, but certainly this side is here, that pharma's there and they're worried about the cost piece and they're going to keep an eye on it, and they want access so that if anything happens, they want to be on the board, they want to be at the decision-making table. And I think there's sort of two sides to that coin. One is they may want to just block anything that they don't like, or they may, if they are not able to block it, they want to be able to go tell their friends in Congress, we don't like this organization anymore. I'm going to skip through this. I already basically told you the upshot of the internet content analysis, that you have to look for pockets of negativity. Overall, you get this really positive story, so nothing there. So what's the bottom line for me? I think that PCORI leadership has thrown themselves into this. Patients are definitely showing up, and PCORI's message about patients first is really out there. There's a potential for an alliance between patients and researchers who are embracing this new style of conducting research, where they really sort of, that partnership in and of itself becomes a new form of mobilization. In talking to people about whether or not, I mean, one thing that really concerns me that I guess I haven't really highlighted here is that patient advocacy. One of the things that we worked on in our general patient advocacy paper, we noticed that patient groups don't tend to form coalitions across diseases. But the patient identity is so strong and so motivating, people don't think of themselves generically as patients. They think of themselves as being part of a community that has a specific diagnosis. And that can be problematic from the standpoint of thinking about how patients might mobilize to support PCORI. Will they mobilize if PCORI is being attacked for something that's not their particular disease? I think that's kind of an open question. Potentially the alliances between researchers and patients are something that will keep both groups sort of more mobilized around PCORI generally than just in this kind of specific disease arena. But one of the things that a key informant told us about this is that these alliances actually also seem to kind of exist around specialty areas, treating specific diseases in patients who have those diseases. And so there's vertical coalition formation, but there's not a lot of horizontal coalition formation. And I think it's an open question about whether or not those vertical mobilizations are going to show up and defend PCORI as a general member. So that's sort of a potential threat there. I think at some point I was wondering if the patient's first emphasis that the leadership is creating might alienate researchers, but I would say most of the researchers that we've seen participating and active really embrace it. And so I don't see a lot of sort of turf battles going on between researcher role and patient role, which isn't to say that there's no stakeholders who come and say, it's too soon for patients to be involved in medical decision making. That happens. But most of the researchers who are getting involved in this already sort of buy into the model, I think, of it. So I think regulatory politics are alive and well around PCORI. Industry and professional associations are occasionally mobilized around the agency. And we have this frame out there of CER potentially not really contributing all that much to clinical decision making. And if that's the argument for why we would fund PCORI, and professionals are able to undermine that in Congress, then that could be problematic. I didn't actually, so one of the things that we found when we looked at the trade association press is that some of pharma has some concerns about whether or not PCORI is going to impact the way that FDA thinks about effectiveness. So they didn't seem too worried about that. I think in general they kind of want to know what their future is and whether or not any of those standards are changing, but they're really sort of focused on that. There's an interview where they're asking a board member about that, and she's like, well, wait a second, let's not get ahead of ourselves. We're just trying to get off the ground. We're not revising any FDA standards. It was pretty interesting. I would say in general that concerns about death panels and government intrusion seems to have quieted down since that early, the PCORI definition comments, where you're seeing a lot of that rhetoric. But at least kind of at the level of public opinion, I think most Americans do not have a good sense of what PCORI is doing or what it's there for, and there's potential to really sort of mobilize there's this latent concern about get the government out of my medical decision making. So whether or not, at this stage, I would say we can't necessarily rule out any of the futures. I think that there's some of what PCORI is trying to create, this distributive environment is happening. But I think it's too early to tell whether or not those regulatory concerns that are really quite alive and well will sort of carry the day. And I would say that just overall, based on what I saw about the congressional hearings, that when members of Congress are interested in this organization, they're interested in a negative way, is the biggest problem that's facing PCORI right now. So thank you so much. I have a few minutes for questions.
I'm curious if you considered adding just did not identify themselves to the bar graphs that you've had. It seems like you would likely get a lot of those, and they would probably give you a better idea of general semi-attentive public opinion than the opinions of researchers or industry or that sort of thing.
So in the data set where we have no idea about who spoke, that's the place where we feel like we've got most kind of the sort of person off the street is actually taking time to comment. So that's an interesting question too. One of the things that there's a really big distinction in how well informed the comments are when you move from the definition comments to the research agenda comments. So in the methods comments, we know who's speaking. It's like two people who gave comments didn't say who they were out of like 100 or 150. We don't know anybody who's speaking in the definitions comments, and we have 50% identification in the research agenda comments. But overall, those tend to be much more highly informed comments. So in some senses, I made the assumption that the average person off the street quit commenting by that point and they're not there. But I take your point that actually sort of mapping out the who's not commenting gives us better insight into what that population looks like.
I suspect, the fact that these comments are ill-informed, there's still a lot of useful things, because it seems like a lot of these, like I said, semi-attentive sort of criticisms tend to run in themes, and that they're going to be banging on 5 or 6 common notes that would benefit from analysis.
Well, so there's not a lot of the low information comments in the research methodology. In the definition one, where we're seeing people where they don't speak about CER, they don't talk about the fact that cost isn't allowed. Like that's what we use to sort of determine whether or not we thought it was sort of high information. And there are themes, and I think the critical themes tend to run along the lines of, this is sort of too much government, it's big and wasteful, and it runs along the lines. The second theme is the government shouldn't be involved. The government shouldn't have any say in what's happening in the clinic between a patient and a doctor. So those are the two big themes that kind of come out there. And I feel like I was going to say something about that. Oh, I think one thing that's really interesting for me as somebody who's done research on mobilizations, citizen mobilizations around environmental policy, is that in general, like maybe environmental groups don't love the EPA, maybe they think it's captured by industry or something, but they generally think that the EPA is more on their side than the oil industry. And in this situation, what we're seeing by the comments that we can't necessarily identify, but the ones that don't seem like they're in the weeds of what PCORI is doing, they trust their physicians much more than they trust the government. And so the likelihood, so it's just a very different environment when in thinking about how EPA experiences the world, because citizen mobilization tries to get EPA to sort of do its job better in some senses, right? To really sort of try to make environmental protections have more public health goods. In some senses, I think that the popular attention to PCORI almost has the reverse potential, because people overall think the federal government can only mess up the relationship that they have with their doctors. So, yeah.
Well, kind of related to that, the whole term comparative effectiveness seems to be getting distorted here in a way, or maybe it shouldn't have been named that, because the fact that it would be representing would have no relevance to clinical decision making is so disturbing and potentially fatal for this effort. So I wonder if you could talk about, who is pushing that agenda? Because maybe what it should really be called is what works. It's actually like data to support evidence for what we're doing. And somehow that's being, distorted to I don't know.
Well, when I talk to people, when I talk to key informants about this piece, about sort of so there's people out there who are saying that comparative effectiveness research just produces these broad population averages, none of it's ever specific enough to help individual decision making. Everybody who was sort of speaking on behalf of PCORI, not PCORI employees, since I couldn't talk to any of them, said that's just ridiculous. We're so this. Not every research design is perfect, but we're looking at specific populations of people. We're looking at whether or not certain treatments work for one population better than another population. That's exactly what we're trying to do. And in some senses, they're very dismissive of the PPIC criticism. In part, I think, and I heard this actually, I heard a couple of times where I got to hear PCORI staff, PCORI employees speak was if I go to Academy Health meetings and they're presenting on panels, and then they say whatever they say and I listen and I'm hearing them. And that's not running afoul of my IRB. But one person was like, as soon as our recommendations come out, people are going to understand what we're doing, and then they'll believe in us, which is exactly what the people said about the low back pain study. So there's a tension here. How easy is it to communicate? And there's also, I think, there's a bigger sort of structural problem. This is kind of a structural problem for public health in general. And AHRQ is facing this right now around trying to defend itself. AHRQ is like, think how many hospital-acquired infections didn't happen because we looked at what worked well and we disseminated that information, and hospital-acquired infections are way down. But you don't know that you didn't. That you go to the hospital, you get treated, and you didn't get a hospital-acquired infection. You're not like, AHRQ helped me. You just didn't get a hospital-acquired infection. And I think that patients that are really keyed into what's happening at this level of decision making, that are thinking about evidence and evidence-based care, get it. But most people, when they go to the doctor, they get treated, they don't know if they got a substandard treatment or the best treatment. And that part of this, I think, is just really, really difficult in kind of a political climate where we don't tend to think the government is a sort of a good faith actor. So that's where an argument like comparative effectiveness research just generates these broad population averages can really take hold in a congressional setting, because I think people have stories about how they got sick and how the doctors made them better. But you don't have a public health story necessarily. I think this also just, I'm probably going on too long about this, but this is part of what's happening with vaccinations, right? People now don't see these vaccine preventable diseases, and so they're not afraid of them anymore. And so I think that's playing out here. That's probably one of the things that's happening. Yeah.
I'd be interested in hearing more about your social media strategy. How did you construct that data? How did you account for the public perception bias? So how people self-construct their own?
We didn't try to, because in some senses, so one of the things we were looking at, like how were people tweeting about PCORI, and tweeting about PCORI was totally uninteresting. Not totally uninteresting, but that like, it's, the people who tweet about PCORI are like the people in this room. And what they tweet about is, hey, there's new PCORI funding research coming out, or there's new, you know, like I got a PCORI grant, or, you know, it's totally, the tweeting universe around PCORI is really the interface between PCORI and the research community. So we weren't really, so there wasn't criticism. I mean, there's a lot of support there. People were happy about this. So that just told this very kind of PCORI friendly, PCORI supportive story. So we didn't do too much with that because we were sort of looking for these, we were specifically looking for these elements of kind of regulatory interest. So then when we were looking for whether or not that happens, we didn't actually try to say who sees this stuff necessarily. We haven't even gotten to that level. Just to say that it's, you know, if generically, if someone said to you, hey, PCORI is really a big problem, you should Google about PCORI, and you wouldn't Google about it, you would get a really positive sort of PCORI-centered story. But if you read about PCORI because the sort of conservative blog that you read picked it up, then you would get this really negative story. And so it is really these. I mean, in general, I think that feature of how we get our news. I mean, everybody used to get news because we sat down at night at dinner and turned on the news, and it was either at CBS or ABC or NBC, and that world just doesn't exist anymore. So people are getting very selected, very specific news that reinforces their beliefs, not that counters their beliefs. And so we didn't see anything in our strategy of looking for these. When we were looking for the targeted negative stories, we were seeing something that kind of reinforced that expectation. So we didn't go too much farther than that. We just said, yep, if you're self-selecting into these you know, more kind of anti-state perspectives, this is what you're going to see. So yeah. I know I run
Thank
over.
you so much. No, it was really, really interesting. Thank you so much.
If everyone has time to fill out evaluation of the work.
So where do you go now?
Yeah. And then I have a little bit of a break, and then I think I have a phone call next. Checking my schedule.
Yeah.
So great. You know, Chase set me up in one of the offices that's used for meetings, and my computer's in there. It's not locked. Is that?
Oh, yeah.
You have to have a badge.
Right. That's what
It's kind of like, you know, what are we hiding?
That's it. We're trying to keep the laptops